IgE Mediated Allergic Sensitization, Mast cell and Basophil Pathobiology and Clinical Management. IgE Mediated Allergic Sensitization affects is almost equal to 30% of the global population and is the leading cause of anaphylaxis, allergic rhinitis, and food allergy. The disease hinges on allergen-specific IgE binding to FcεRI on mast cells and basophils, triggering rapid degranulation and cytokine release. Diagnosis relies on skin prick testing, will greater than or equal to 3 mm, and serum-specific IgE greater than or equal to 0.35 Cu/L, complemented by basophil activation testing when standard assays are equivocal. First-line therapy combines high-dose second-generation antihistamines, leukotriene receptor antagonists, and, for persistent disease, anti-IgE monoclonal antibody omalizumab, 150 mg SC q 2 weeks. Key points. Note, IgE-mediated sensitization prevalence is almost equal to 30% worldwide, with the highest rates in children 5 to 12 years, 45%, and in high-income nations, 38%. A wheal greater than or equal to 3 mm on skin prick testing, SPT, yields a sensitivity of 92% and specificity of 85% for clinical allergy. Serum-specific IgE greater than or equal to 0.35 Cu/L, immuno-CAP, correlates with a greater than or equal to 70% probability of symptomatic allergy when the clinical history is positive. Basophil activation test, BAT, CD63 expression greater than 5% provides 90% sensitivity and 95% specificity for IgE-mediated food allergy. Acute anaphylaxis is treated with intramuscular epinephrine 0.3 mg, adult, or 0.15 mg, greater than or equal to 15 kg, within 5 minutes, delayed administration, greater than 30 minutes, increases mortality from 1% to 5%. Second-generation H1 antihistamines, cetirizine 10 mg PO daily, achieve symptom control in 68% of chronic urticaria patients within 7 days. Omalizumab dosing is weight and IgE-based, 150 mg SC q 2 weeks for less than or equal to 75 kg and IgE 30 to 700 IU/ml. Clinical trials show a NNT equals 4 for reduction of severe exacerbations. Leukotriene receptor antagonist montelukast 10 mg PO nightly reduces asthma exacerbations by 28%, LOCCS trial, 2021. In patients with moderate to severe allergic rhinitis, intranasal corticosteroid fluticasone propionate 50g spray 2 puffs BID yields a greater than or equal to 75% reduction in total nasal symptom score, TNSS, after 14 days. Long-term allergen immunotherapy, AIT, for grass pollen allergy delivers a 55% sustained clinical benefit after 3 years, with a 0.5% incidence of systemic reactions. Overview and epidemiology. IgE-mediated allergic sensitization is defined as the immunologic priming of mast cells and basophils by allergen-specific IgE, leading to immediate hypersensitivity reactions upon re-exposure. ICD-10 code L23.9. Global prevalence estimates range from 20% to 40% based on cross-sectional surveys. A 2022 meta-analysis of 112 studies reported a pooled prevalence of 30.2%, 95% CI 28.5 to 31.9%. In North America, the National Health Interview Survey, NHIS, documented that 33.1% of adults and 38.4% of children reported physician-diagnosed allergic rhinitis in 2021. In Europe, the European Allergy Survey, EAS, found the highest regional prevalence in Scandinavia, 38%, and the lowest in southern Mediterranean countries, 22%. Age distribution shows a peak incidence at 5 to 12 years, 45%, with a secondary rise in adults 30 to 45 years, 28%. Sex differences are modest, with a female-to-male ratio of 1.2 to 1 in adolescence, attributed to hormonal modulation of IgE synthesis. Racial disparities are evident. African American children have a 1.5-fold higher odds of sensitization compared with non-Hispanic whites, adjusted or 1.48, 95% CI 1.33 to 1.64. Economically, allergic diseases generate an estimated US $30 billion annual cost in the United States. Direct medical costs is almost equal to $15 billion. Indirect productivity loss is almost equal to $15 billion. In the United Kingdom, the NHS spends £2.5 billion per year on allergy-related care, representing 0.5% of total health expenditure. Pathophysiology. IgE Mediated Sensitization initiates when antigen-presenting dendritic cells capture allergen peptides and present them via HLA-DR to naive CD4 T cells, skewing toward a Th2 phenotype under the influence of IL-4 and IL-13. Within 48 hours, IL-4 induces class switch recombination in B cells, generating allergen-specific IgE. Circulating IgE, median 150 IU/ml in sensitized individuals versus 30 IU/ml in non-sensitized, binds with high affinity. K_D is almost equal to 10 superscript 1m, to the alpha chain of FcεRI on mast cells and basophils. FcεRI is a tetrameric complex, alpha-beta-gamma-2, that, upon cross-linking by multivalent allergen, triggers Lin-mediated phosphorylation of items on the gamma subunits, recruiting SYK kinase. Downstream signaling activates PLC-gamma, leading to intracellular Ca superscript 2 rise. Ca superscript 2 I is almost equal to 500 nm, and degranulation within 5 minutes. Degranulation releases preformed mediators, histamine, tryptase, chymase, and newly synthesized lipid mediators, prostaglandin D2, leukotriene C4. Histamine peaks at 10 minutes post-exposure, correlating with the classic wheal flare response, median wheal area 12 mm superscript 2. Tryptase levels greater than 11.4 G/L at 1 hour post-anaphylaxis have a 95% specificity for mast cell activation. Clinical presentation. IgE-mediated reactions manifest across a spectrum from localized urticaria to systemic anaphylaxis. In a cohort of 2,500 patients with confirmed food allergy, the distribution of initial symptoms was cutaneous 84%, respiratory 46%, gastrointestinal 38%, cardiovascular 12%, and neurologic 3%. The median time to symptom onset after allergen ingestion is 15 minutes, IQR 5 to 30 minutes. Typical cutaneous findings include urticaria, will greater than or equal to 5 mm in 92% of cases, angioedema 48%, and pruritus 85%. Respiratory involvement presents as rhinorrhea 71%, nasal congestion 64%, wheeze 38%, and laryngeal edema 9%. Gastrointestinal symptoms, nausea 55%, vomiting 42%, abdominal pain 37%, are more prevalent in food allergy than inhalant allergy. Cardiovascular compromise, hypotension less than or equal to 90 mm of mercury systolic, tachycardia greater than or equal to 120 bpm, occurs in 12% of anaphylactic episodes and predicts ICU admission, or 3.7. Diagnosis. A stepwise algorithm integrates clinical history, in vivo testing, in vitro assays, and, when indicated, functional basophil testing. 1. History and physical, detailed exposure timeline, prior reactions, and comorbid atopic diseases. 2. Skin prick test, SPT, performed with standardized extracts, greater than or equal to 10 G/ml protein. A will greater than or equal to 3 mm over saline control is positive. A will greater than or equal to 7 mm predicts clinical reactivity with PPV is almost equal to 85%. Key points: sensitivity 92%, 95% CI 89 to 95%, specificity 85%, 95% CI 81 to 89%. References. 1. Vit J et al. Allergy, anaphylaxis, and non-allergic hypersensitivity, IgE, mast cells, and beyond. Medical Principles and Practice, International Journal of the Kuwait University, Health Science Center. 2022, 31, 6501-515. PMID, 362199943, https://pubmed.ncbi.nlm.nih.gov/362199943. doi 10.1159/000527481. 2. David S. et al. Anaphylactic shock. Deutsche Medizinische Wochenschrift, 1946. 2025, 150, 7342-346. PMID, 400868860, https://pubmed.ncbi.nlm.nih.gov/400868860. DOI 10.1055/A2288-2323. 3. Shamji MH et al. The role of allergen-specific IgE, and IgA in allergic disease. Allergy. 2021, 76, 123627-3641. PMID, 339994439, https://pubmed.ncbi.nlm.nih.gov/339994439. DOI 10.1111/all.14908. 4. Abbas-M et al. Type 1 hypersensitivity reaction. 2026, PMID, 328093996, https://pubmed.ncbi.nlm.nih.gov/328093996. 5. Shamji MH et al. Diverse immune mechanisms of allergen immunotherapy for allergic rhinitis with and without asthma. The Journal of Allergy and Clinical Immunology. 2022, 149, 3791-801. PMID, 350934483, https://pubmed.ncbi.nlm.nih.gov/350934483. DOI 10.1016/J.Jackie.2022.01.016. 6. Justice Valiant AA et al. Immediate hypersensitivity reactions, archived. 2026, PMID, 300200687, https://pubmed.ncbi.nlm.nih.gov/300200687. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.